Hi, my name's Andrea Rinderknecht. I am a physician, board certified in pediatric emergency medicine and general pediatrics, and I work as a general pediatrician in a private practice. And I'm here to talk today about a case study, baby CO. Baby CO was born to a mom who had an unremarkable pregnancy. She had gestational diabetes. Because of that and the baby's size, he was born by C-section at 37 weeks and 4 days. His birth weight was 3.25 kilograms, which was the 42nd percentile on the WHO growth chart. He had an uneventful nursery stay, no sequelae of the gestational diabetes, and he ended up having a normal newborn screen. There was some early breastfeeding difficulty. He ended up having a sublingual frenotomy because he had a tongue tie. Mom was using a nipple shield for nursing, but things got much better after the frenotomy. He had some mild right torticollis, which didn't impact his ability to feed. He had some age-typical fussiness and gas pains, for which we tried some probiotic drops and some methicone as needed, and he seemed to do well with that. And he was growing well through 6 weeks of age, maintaining the 12th percentile on the WHO growth chart, which you can see here. Nice growth pattern. However, at his 4-month well check, there evolved some growth concerns. At that time, he was nursing on demand, feeding 7 to 8 times per day for 20 to 30 minutes at a time, typically every 3 hours from 6 a.m. to 8 or 9 p.m., and he seemed satisfied. He wasn't typically waking up at night to feed or seem hungry. He would usually finish 3 ounces when he was given a bottle of pumped milk. He had no cyanosis, no sweating during feeds, and no fast breathing, and seemed to be generally doing well. He had stools every other day that appeared normal in texture and normal urine output. But as you can see from his growth chart, there was a concern about his weight gain. His weight at the 4-month assessment was 4.67 kilos, and the percentile had fallen to the 0.02 percentile on the WHO growth chart. His rate of weight gain in the last interval was only 5.8 grams per day, a total of 350 grams in about a month. His physical exam was reassuring. He had mild head lag, but otherwise normal tone. And there were no focal or concerning physical exam findings. For example, there was no murmur, no abdominal distension or mass, no palpable thyroid, and he was well perfused and pink and vigorous. Failure to thrive or growth faltering became apparent, but he was otherwise thriving and developing well. At that time, our differential diagnosis included 3 main categories that lead to failure to thrive: inadequate caloric intake, impaired absorption from a primary GI pathology, or increased demand. So, for example, congenital heart disease, metabolic disease, or thyroid disease. And since he was thriving and developing well, we decided first to increase the frequency of his feedings to 8 to 10 times per day, and to have close follow-up in 2 weeks for reassessment of interval weight gain. At that 2-week follow-up assessment, his weight was 4.8 kilos, which was still at the 0.02 percentile on the WHO growth chart. His rate of weight gain was 9.5 grams per day. The family had added 1 to 2 feeds per day, so he was now taking 8 to 9 feedings per day, and there were no other changes. He was still doing well, and his exam was normal. At this point, we planned some screening labs to rule out metabolic dysfunction, anemia, renal dysfunction, inflammatory processes that could be requiring additional caloric demand, and so those were ordered. At his next checkup at 4 months, his weight was 4.8 kilos, which was still at the 0.02 percentile. The screening labs were all normal. He was nursing ad lib and bottle feeding with pumped breast milk 3 times a day, and each time he would take about 3 ounces. So at that point, we observed a nursing session in the office, and after nursing and seeming satisfied, he had only gained 1.5 ounces. Additional, more detailed history was obtained about nursing and mom's health, and it came to light that she had returned to work at the baby's 3-month age, at 3 months of age, and she was pumping and offering expressed breast milk, but she had started menstruating 3 months postpartum. So at that point, our differential diagnosis shifted to a suspected under-recognized decrease in mom's breast milk supply and inadequate caloric intake with nursing. So at that time, we needed to figure out how to add calories to this baby's nutrition so that we could show that he could otherwise grow normally. So the care plan was to continue nursing or offering expressed breast milk 8 to 10 times per day, but also to start a high-calorie supplement to breastfeeding, taking 1 or 2 ounces of Fortini after each feeding. At a 5-month weight check, a few months later, mom was nursing, including offering both breasts each feed, which was something that we had discussed, and she was supplementing with the Fortini for 6 feeds, 2 ounces each time after nursing. And the parents reported increased bowel movements, no constipation, and that he was tolerating the formula great, that he was happy, sleeping better, and had dropped a middle of the night feeding once. And at that time, his weight had come up to 5.3 kilos, up to the 0.13 percentile on the WHO chart. So we decided to continue that routine and see him at intervals to make sure he maintained this improvement in growth and weight gain. Half a month later, at a sick visit, his weight had improved to 6 kilos, the 1.56 percentile. And at his 6-month well check, his weight was up to 7 kilos, 0.2, and the 18th percentile on the growth chart. So at that time, we were able to pull back the high-calorie formula and return to nursing with a standard formula supplement as needed, since mom's breast milk production had improved with the extra pumping and attention to the schedule. So in conclusion, this case study was a perfect example of a successful short-term supplementation with an energy and nutrient-dense formula in a breastfed infant with growth faltering due to inadequate caloric intake from an unrecognized decline in maternal milk supply. The mother and the infant were able to continue to work on supply and breastfeeding. There were no side effects. The baby tolerated Fortini well as a supplement, and the rapid progress allowed for safe outpatient monitoring and ongoing successful breastfeeding support, which was sustained after the intervention concluded. He had a wonderful outcome.